So I want to start out with a big thank you to Summit for having me out here to speak with you this afternoon. It's always an honor when we get to come and speak to groups this size. And I like to think that my topic is almost as important as their topic, right? And so what we're going to try to do here is give you a lot of the information that allows you to understand what is coming in the future if you're not yet Medicare eligible, and the changes that are happening this year if you're already enrolled in Medicare. I'd like to begin getting to know you just a little bit. How many people here are already Medicare eligible? Almost the entire room. Anybody here not Medicare eligible yet? Okay, so we do have a few people planning for the future. Very good. That's a smart thing to do because not getting this right can have significant consequences down the road. Second question, we've got a big transition going on this year. How many of you are enrolled in a cost plan that's ending at the end of this year? Okay, quite a lot of you. Are there some people in here that have a different plan, a Medicare supplement or a Medicare Advantage plan? A couple. Okay, so we'll have information for all of you. One important thing to understand about the presentation that we're going to be doing today is all Medicare seminars are governed by CMS, the Centers for Medicare and Medicaid Services. And in order for me to maintain my license, I need to follow and respect those rules. I do like to ask this question also at the beginning. Is there anyone in here from CMS? Is there anyone in here from the Department of Commerce? Is there anyone in here from a carrier auditing my presentation? Okay, so just because those people aren't in the room doesn't mean I'm not going to respect those rules. I'm still going to follow those rules, right? And so in a seminar like this, I can't name the carriers, okay? I can't name their premiums. I can't name their benefits. What I'm going to try to help you understand is how to get into Medicare, how the different plans work, how to evaluate the pros and cons of the different plans, and how to deal with the transition that's happening this year that's unique and for some of you painful. Okay, with that kind of a start, let's see if I can't operate the equipment here. So there's me. Here's back to our title slide, and now we're in. So from the perspective of the official presentation, I'm covering three main points. The first point is that if you don't enroll in Medicare on time, you may be subject to late enrollment penalties. Some of those penalties are significant. Some of those penalties could last for the rest of your life. Second key point that we're going to talk about is the importance of selecting the right insurance. That's probably the one that you're all most interested in. Okay, so we're going to spend a lot of time on that. And the third one, and this I think a lot of people skip over, and while this is not going to be the primary focus of our conversation today, I want to make sure that we spend some time on it, making sure that we plan for higher healthcare costs in retirement. That is going to happen. And if you haven't made a plan for it in advance, that can derail all of the other plans you have. So when Scott did his introduction, he talked about return on life. It's important that this be a part of your plan if you're going to actually achieve that goal, okay? So to get a little bit more into the agenda, in that first part, we're going to talk about what is Medicare, who needs to enroll in Medicare, and how you enroll in Medicare. I'm going to try to spend enough time on that to really satisfy those of you who are new. But I'm going to try not to spend so much time on that the majority of you feel left out, right? Because for the majority of you, you want to talk about the plans, and I want to make sure that's where we spend the bulk of our time today. And that's really the second part of our agenda. So we're going to talk about what Medicare covers and what it doesn't cover, how much it costs, and what you may need to do to properly pair private insurance with original Medicare A and B. And finally, we will talk about those higher costs. My guess is everyone in this room has experienced inflation. That will continue to happen in the future, barring a serious disaster. And the other thing that people are aware of, but they don't really think about or quantify, is the impact of the increased need for services as you get older, right? I don't want to pick on anyone, but I can hear the oxygen, right? That's an impact. That's probably not something that you're all going to need when you're 65. You might not need it until you're 75 or 85 or whatever, but that changes your costs, right? And what works perfectly when you first go on Medicare may not work as perfectly later if you haven't built a robust plan that can accommodate those changes in your health. The other point that we will emphasize but not try to spend an overly long amount of time on is that Medicare does not cover long-term care. And that is financially devastating for people who do not build that plan. And so we'll spend a little bit of time on that as well. So let's get started and get into the meat of the presentation here, Medicare enrollment. So as many of you may already know, healthcare in the United States is covered primarily by employers. And that continues to be the case until people turn 65. At that point, there's kind of two options. You can keep working, and some people have to do that, or you can go on Medicare. And Medicare is primary for most people. There's an exception for those people who are working for an employer who is larger than 20 employees or whose spouse is actively at work working for a large employer. Those people, their employer-sponsored insurance will continue to be primary, okay? This is a slide that kind of really emphasizes that 20 employee piece, okay? And so if when you turn 65, you don't enroll in Medicare right away and you're not employed by, or you don't have a spouse who's employed by one of those large employers, three things can happen if you don't enroll in Medicare on time. First thing is you can be subject to late enrollment penalties. And while those penalties may start out small, the Part D penalty is 1% per month. So if you're a month late, it's not a big penalty. It is for the rest of your life. And there are practical considerations owing to the fact that you can't just enroll in these plans at any time. So you may have to wait up to 12 months to enroll in that plan. The second thing, and perhaps this has occurred to all of you, if you don't have insurance, you're on your own if you actually have medical expenses. And that's a bigger deal probably for most people than the penalty. And the third issue, and this can be a big issue for people because of the impact over time, is that it can actually limit the number of plans that you can select from when you select your plan. And if you want a particular type of plan and that plan is no longer available, that's a big deal. So we want to make sure that we can help you enroll in time. Medicare is national health insurance, primarily for people over 65, but also for people disabled and with certain special conditions. It's administered by CMS, the Centers for Medicare and Medicaid Services, but enrollment is handled by the Social Security Administration. If you are not a citizen, you may qualify for this program if you have worked in the United States for at least 5 years. However, you pay a significantly higher premium. And so most people who do immigrate to the United States and want or need Medicare have a tendency to work at least 10 years in order to get the full benefits. And that's good, of course, for the people who are citizens of this country, because that means they've paid in some meaningful amount of taxes to help support the program. Original Medicare is made up of Medicare Part A and B. These were created in 1965 and forms the core of the health insurance benefits for our population of people 65 and older. Medicare Part C was not created until 1996 and was really a privatization or a partial privatization of Medicare, where original Medicare benefits as well as additional Medicare benefits are administered by private companies. At that time, there was still no Medicare Part D, and prescription drug coverage was not a part of the program. That did not occur until 2006. Since then, Medicare Part D has also been integrated into Medicare Part C, the Advantage programs, sometimes also called MAPD. Both Medicare Part C and D are administered exclusively through private companies with contracts with the federal government. So none of those benefits can be had directly from the federal government, only original Medicare A and B. This slide is actually where I spend most of my time in the presentation, okay? And so if you're gonna take notes, right, now's the time to do it. We're gonna talk about the two different ways you can combine original Medicare with a supplement or replace it with an Advantage plan. So on the left, you can see what has been the traditional route and that has existed since 1965. Part D, of course, coming much later in 2006. But you could add a supplement. Medigap plans have several unique and important features. First of all, every doctor who accepts Medicare must by law accept every Medicare supplement. So network is not a problem when you buy a Medicare supplement. Now, if you listen carefully to that, you probably heard the catch. The catch is that the physician has to accept original Medicare. There are about 2% of physicians in the United States that do not accept original Medicare. And if you want to see that doctor, it will be a private pay arrangement, okay? But for the other 98%, you now have access to effectively everybody. The second thing that's important to know about traditional Medicare supplements is that they're portable. If you buy this plan and you buy it based on where you live at the time you purchase it, you can take it with you no matter where you go or how long you go there, including permanent relocations, whether that's domestically here or internationally. And I have a number of clients who have married foreign spouses, and so they spend half a year or more abroad. And I've also got some clients who seem to like to live on ships and cruise a ton. And I've got some people who just like warmer weather, and they get seriously far away from Minnesota during the winter. So those benefits can be very important to people. Medicare supplements are also what's called guaranteed renewable, meaning the benefits themselves cannot change. Again, almost everyone raised their hand when I asked the question, how many of you are being impacted by the cost plan transition, right? That's clearly not a guaranteed renewable plan. If you like going through this process, right, you don't need a Medicare supplement, right? But if you don't want your plan to change like that, year in, year out, or have the potential to change year in, year out, you may want a Medicare supplement. The last thing that I want to emphasize about traditional Medicare supplements is that they're the only plans that can get you, if you want it, 100% medical coverage. Now, I'm not saying 100% coverage on your prescriptions. I'm not saying 100% coverage for dental or vision or hearing. I'm talking about the core Medicare A and B benefits at the hospital, the clinic, the testing, transplants, immunosuppressive drugs, physical therapy, things like that, right? Those things could be covered 100% if that's what you wanted from your Medicare supplement. Now, I'm guessing that many of you can intuitively figure out lots of guarantees, 100% coverage, not cheap, right? You're right. Those are not the cheapest plans. But for some people, that is what they want or need, right? Because you cannot get those benefits from any other plan. And so if you're in the category of needing those things or wanting those things and being willing to pay for them, that is the way to get them. How does the other type of plan work? And I'm going to emphasize this, I'm actually going to go to the other side of the room, right? Advantage plans work very differently. Advantage plans are a lot like health insurance you've had in the past. Advantage plans are administered by private companies. They combine original Medicare A and B. They include prescription drug benefits. They may include extras like dental, vision, hearing, gym memberships, over-the-counter medications, right? They can have dramatically lower premiums, but they have networks. They're subject to change from year to year. They can be terminated, right? They're not guaranteed renewable. They're not portable. And so it's a very different value proposition, right? That's not to say it's good or bad. That's to try to help you understand how they're different. I want to make a couple more comments about these plans, and I want you to think a little bit like I do. I'm going to presume that that's a good way to think, right? And I want you to think about the sort of analysis that we do for our clients. You can buy 100% medical coverage, but it's going to cost you at least $135 a month for Medicare Part B. Everybody's going to pay that, unless you're very low income or you're high income, and the federal government has a chart for that, for the income-related monthly adjustment amounts, but most people are going to pay $135. Then you're going to have to add a supplement. Typical supplements in the state of Minnesota, if you want 100% coverage, are north of $200 a month. I have a slide later where I will put up the number 200. That's actually low for the state of Minnesota. That's a national average, right? You're going to add over $200 a month to get that supplement. You still don't have coverage for prescription drugs. So you're going to add, on a national average, another $40 there. If you want dental, that comes in a wide range. You can get plans for as little as $20. I've seen people spend more than $60 a month. Let's call that another $40. Okay? You want coverage for vision? That's another premium. You want coverage for hearing aids? That's another premium, right? And pretty quickly, you're north of $400 or $450 a month. You're talking about north of $500 a year in premium. Did I say that right? 5,000? And we haven't added out-of-pocket costs for dental, or out-of-pocket costs for prescriptions, or out-of-pocket costs for vision, or out-of-pocket costs for services that aren't covered by Medicare at all. Say you want to do Eastern medicine, or you want to do acupuncture, or you want to do something else. And if you're married, a few of you in here married, I'm guessing you guys came together, same last names, as my clue. No, different. I thought it said those are not the same at all. You just happen to be sitting next to each other, and so I made an assumption. My bad. I apologize. You start to add all that stuff together, right? And you end up at some big numbers. You put a couple together. If we form a new couple here, right, it's $10,000 a year, and we haven't used any care yet, right? And you do that over long periods of time, and you're talking about very large sums of money. And again, Medicare doesn't cover long-term care. So I'm giving you a flavor for it, right? On the other side, Medicare Advantage plans can be had for as little as $0 a month. And they can build in dental and vision and hearing and gym memberships and other things. Now they're going to have out-of-pocket costs, but you've got to weigh out, right, your relative health and your longevity. If you could save $5,000 or $10,000 a year in premium, that potentially gives you a lot of room to pay for out-of-pocket costs, right? And so this is the trade-off we help our clients think through, right? What is the likely outcome for me? What is the likely best outcome, right? But again, I don't have a crystal ball. I can't predict the future. I can't guarantee that the plan that I may recommend to you or that you may select is in fact retrospectively going to be the very best plan that you could have selected, okay? So how do you enroll in Medicare? If you're enrolled in Social Security, it'll be automatic. If you're not enrolled in Social Security, you need to contact them to do that. We can help you with that. C&D is not automatic. The Advantage plans and the Part D plans, we can help you with that. If you're not receiving Social Security, you have 3 different times when you can do this. Your initial enrollment period when you first turn 65, a special enrollment period if you or your spouse was working longer, the general enrollment period if you missed the other 2. You don't want to use the general enrollment period. You want to use the initial enrollment period or the special enrollment period. That is a graphical representation of the initial enrollment period. It's the 7 months centered on your birthday. The 3 months before, those are the best, the month of your birthday and the 3 months after, okay? Pretty much everybody signs up for Medicare Part A when they turn 65 unless they're enrolled in an HSA compliant health insurance plan, typically through their employer, and they're taking advantage of that HSA and the tax savings that come along with it. The reason those people don't is enrollment in any part of Medicare, even the free part, disallows the tax advantage contributions to the HSA. So who does sign up for Medicare Part B? Pretty much everybody else, right? So if you're self-employed, if you're not working, if you're employed at a small employer with less than 20 employees, if you're on COBRA, if you're receiving retiree health benefits, or if your company's benefits are stingy, even if the employer is larger. Okay, pretty much everybody who signs up for Medicare Part D also signs up for Part D. Tends to start to come as a package at that point, because if you need the medical, you probably need the prescription drug coverage as well. You can get that prescription drug coverage one of 2 ways: as a standalone prescription drug plan or integrated into a Medicare Advantage plan, okay? The special enrollment period, again, is primarily for those who worked past 65 or whose spouse worked past 65 and they carried health insurance from one of the large employers. You have 63 days after that active employment health insurance ends for Part D and 8 months to add Part B. Really, the important one is the 63 days for Part D, because if you've got to add Part D, you're probably going to be best off adding everything at that point. So the 63 days for most people is the key trigger. Best time to enroll in Medicare is when you first turn 65 or as soon as you go off of group-sponsored insurance. Most people that work with us will contact us in advance so that they can try to coordinate care and have no gap in coverage. The general enrollment period, which I've had a few clients use over the years, runs from January through the end of March, but new coverage doesn't begin until July 1st. That puts a big gap in your coverage. And that big gap in coverage can lead to a lot of out-of-pocket costs if you're unlucky and you have a health event during that period. So we really don't want to use that unless we absolutely have to. And really that means we've screwed up, right? Again, initial enrollment period, special enrollment period, general enrollment period, those are the 3 periods that you can use. You can sign up on Social Security Administration website. You can go to Medicare.gov and they'll redirect you there. You can call up on the phone and have them mail you the paper forms. You can go into your local Social Security Administration office. Almost everybody that we work with enrolls online unless there's some problem with their records, in which case they pretty much have to go and do it on paper and often in person. Medicare Part D is always done through private companies. We assist with that. You can also do those searches on your own at Medicare.gov. We use Medicare.gov. We think that's a very valuable tool. We've also seen people make some pretty big mistakes on there. That's not to say that the information they got on Medicare.gov was bad. And it's not to say that the people who made these decisions aren't intelligent people. But if you misread it, right, you can come to the wrong conclusion. And we've certainly met a number of people who have done that. The other thing that happens is the plans change, the premiums change, the benefits change, the tiers that the drugs are in change, the formulary itself can change, the pharmacies that are in network or in a preferred versus a standard category can change. And you can get different results for what plan is the best for you based on the different data that you entered into the system. And so again, we strongly encourage everyone to be very careful with when they do that. And there's no cost to use us or another professional to do that for you. We're going to talk a little bit more now about Medicare and private insurance. Again, I covered a lot of this on that slide early on, but here we're going to start emphasizing some of the pieces, and we'll, at the end of this, talk again about the cost plan transition and what you're going through without naming any names, okay? So this is an important slide for me conceptually as a geek, right? To understand that a little less than half of all Medicare expenses are premiums, and a little more than half are out of pocket. But it's also important to understand how these things are built up and how they change over time. What you will see higher up on the screen here is that a major part of the out-of-pocket services come from long-term care. And so if you're leaving that out of your plan, that's potentially going to be a big impact. The other thing that's important to understand is while everyone has this risk, the claims do not follow the averages, right? Most people either have very small claims and a small number of people have very large claims, right? And that's how we end up at the average. The long-term care claims tend to not matter or be catastrophic. That's what I'm trying to emphasize to you, okay? If we, it must be a couple slides further up. That's okay. So what generates the out-of-pocket costs that people have? Well, we talked about premiums. Part A is 0, Part B is $134 now. It's going to be $135.50 next year. Drug plans have premiums, supplements have premiums, Part D plans have premiums. But there are other out-of-pocket costs, right? Original Medicare has a deductible for Part A at the hospital, $1,364 each admittance, or for each benefit period. A benefit period is defined as being single period as long as you haven't been out for 60 days. Once you've been out for 60 days, if you go back, it's a new period, new deductible, okay? There's the Part B deductible is $183 today. It's going to be $185 for next year. So most people aren't that afraid of the Part B deductible. But original Medicare is essentially 80-20 coverage with no cap. And I've been telling people for years, this is good news, bad news. Good news is no matter how big your bills get, Medicare is going to pay 80%. The bad news is no matter how big your bills get, you got to pay the other 20%. And if I could raise my hands up high enough, this one would get pretty darn high, right? So that's the reason that most people want some sort of supplemental or coordinating care. The Part A premium, again, for most people is 0. If you have less work experience, you have a higher premium. You've got the standard Part B for 2018 there. Again, 2019 is $135.50. Part D will vary by plan. I will tell you for next year, the range is from about $15 to about $100 a month. So that's a wide range for Part D. Again, the average is around $40. There are income-related monthly adjustment amounts. I won't ask any of you to tell how much money you're earning, but I will tell you that there's a big difference between paying $174 a month for Medicare A, B, and D and paying $543 a month for Medicare A, B, and D. And again, if you're a couple in this category, you're at almost $1,100 a month, and you haven't added a supplement yet. So I have couples who are spending $1,500 plus a month in premiums, $18,000 a year. Yeah, I get it. They're making a little bit more income, but that's still a ton of money to be spending on health insurance. And I wouldn't want to spend that amount of money on health insurance when I know my neighbors are paying a lot less for the same benefits. So I want you to be aware of that. If you want to go into more detail on that, we can. There are important differences between modified adjusted gross income, that's MAGI up there, and adjusted gross income. So if you think that this could be something that's going to affect you, if you're close to any of those cutoffs, we're happy to have a conversation with you. Okay, deductibles, we talked a little bit about these. These are the 2018 numbers. Again, 2019, it's going to be $1,364, $185, and $415. So not big increases, but all of them did go up a little bit. There are daily copays if you're in the hospital for a long time. It's 80/20 coverage if you are on Medicare Part B using doctor services, et cetera. In Minnesota, excess charges are not allowed, but in most of the country, doctors can tack on an extra 15%. Some plans pick that up in full, some plans don't touch it. It's important for you to understand how that benefit works if you're going to do a lot of care outside of Minnesota, where you're going to be subject to that. But again, the key is a lot of care outside of Minnesota. Unless you're living there or you're there for very long periods of time, the odds of your getting care in these other places is quite low. How many of you ever in your life while traveling had an emergency where you had to go to the emergency room? 2. I'm guessing all of you have gone on vacations though, and I'm guessing many of you have gone on many vacations over the course of your life, right? It's not normal to need to do that, but it does happen, right? We have 2 people who experienced it, okay? How many of you going on one of those vacations ever in your life went to the doctor for anything? Not many more hands, not many more hands, right? So again, some people freak out about excess charges and they make it a super big deal. I personally think it's massively overblown if you live in a state like Minnesota, right? If you live in that other state and you're getting all of your care there, it's potentially a big deal. But if you live here, and this is where you do your hip replacements, and this is where you do your knee replacements, and this is where you do your kidney transplant, and this is where you do your rehab, and this is where you do the big stuff, excess charges aren't going to happen to you. Final comment on excess charges, you can actually look at the MedSups in the state of Minnesota and see how they assign the premiums to the basic plan and to each of the riders. The amount of premium assigned to the excess charges rider tends to be on the order of 0.5%. It's an incredibly small premium, often in the neighborhood of $1 a month. They're telling you this is not something that they are seriously worried about. They're not charging much for it. They charge 4 times as much to give you a $120 a year benefit for preventative services that original Medicare doesn't cover, right? So again, for me, not a big deal. If it's a big deal for you, we can show you plans that cover that. But I think it's oversold and it's overblown if you live here in Minnesota. Standard feature design of Medicare Part D. All plans have a deductible. I love it that they've got good 2018 numbers in here. So it's currently $405. It's going to be $415 next year. You have to pay all of that if you have a standard plan before the plan kicks in. Some plans can choose to reduce or waive that deductible for some or all tiers. Often when they do that, they're going to either increase the premium or increase copays on other things because there is no free lunch. Okay, just want to be clear on that. After that, you go into what's called the initial coverage level, where you generally speaking have copays for your prescriptions. Some plans have coinsurance. The difference is a copay is a fixed dollar amount, $5 say for a prescription. Coinsurance is a percentage, 15% say. And so conceptually, some people like knowing it's $5 versus 15%, 15% of what, right? 15% could be less than $5, right? It depends on the cost of the drug, but psychologically, some people have trouble with the uncertainty that the coinsurance brings. If your drug costs exceed, here we've got $3,750. I think for next year, it's a little over $3,800, that level. And that includes what you've spent and what the insurance company has spent on your behalf. You go into what's called the coverage gap, the donut hole. Nobody has ever liked the donut hole, except for some nerds in Washington at the CBO, where they score things because the donut hole made this law, Part D, affordable. And when they tried to get rid of it as a part of the ACA, they all scratched their heads going, oh my God, this is like the most expensive thing ever. And that's why they did it over 10 years, right? Because it was very expensive to get rid of the donut hole. But next year is the last year of the donut hole. So if you are experiencing that, you're nearing the end, okay? And next year should be less expensive than this year. Of course, that assumes you don't need new expensive drugs, right? If your drug costs exceed about $5,000, next year I think the number is $5,100, you will go into catastrophic coverage. At that time, you have fixed small copays for generics and brand names, or 5% of the drug's cost, whichever is more. Medicare covers 100% of your hospital stay for the first 60 days, except the deductible. Medicare covers 80% of most of your Medicare bills and 100% of quite a few different preventative services. What it doesn't cover, we've talked about long-term care before, we'll talk about it more later, care outside of the US, although most of your supplements or Medicare Advantage plans will help with emergency care outside of the US. Original Medicare doesn't cover dental, vision, or hearing aids. I would suggest to you that those groups have good lobbies, but that's an aside. Medicare doesn't cover cosmetic surgery, but it does cover reconstructive surgery after an illness or an injury, right? Medicare doesn't cover acupuncture or other alternative care, although again, not supplements, but some Advantage plans may cover that. Medicare does not pay any amount above its approved amount, which is why we were talking about excess charges before, because those are charges in excess of what Medicare approves. And Medicare obviously doesn't cover the deductibles and the coinsurance, right? That's what you're responsible for. And all of that is what private insurance is for, right? That's why people buy Advantage plans or traditional Medicare supplements. It's to deal with most or all of these things that Medicare doesn't cover, because there is no cap on what those things could add up to, okay? So we talked a little bit about Medicare supplements before on the slide that I expanded on, right? So private health insurance offer these, premiums vary, benefits are standardized. You can see any doctor who accepts Medicare, and they can't change the benefits in the future. That's what federal and state laws that protect you is all about. We're in one of the three funky states, Massachusetts, Minnesota, and Wisconsin. You can't have both Medicare Advantage and MedSup. And so what we have on this slide are the alpha plans that apply nationally. Again, you're in a funky state, Minnesota, right? And so in Minnesota, we have what's called a basic plan and riders. And using the basic plan and riders, we can reconstruct plans A through G. Okay, the other plans came about later, and we actually have to use the letter names for those. We also have a plan that I believe is referenced at the bottom, high deductible plan F, okay? So some people want 100% coverage, and I talked about that with respect to Medicare supplements before. That's your plan F, 100% of everything received within the US. The only exception is the foreign travel, right? Where it's 80% coverage instead of 100. But again, it's 100% within the US. For some people, that's the perfect balance of benefits and premiums. For many people, I would suggest that that's overkill. And so you may want to consider one of the other plans, whether it's a lettered plan or a basic plan plus some combination of the riders without being all the riders. You can also choose an Advantage plan. People choose Advantage plans for a few different reasons. Some people choose them strictly for the lower premiums. They can't afford a MedSup. Some people choose them for the extra benefits they build in, the dental, the vision, the hearing, the gym membership. Some people choose them for the network, right? When you start to restrict the number of doctors that you can see, you start typically excluding the expensive ones first. And so that starts driving costs down. Now, you need to be fairly committed to staying in that network because your costs go up dramatically when you go outside of the network. But depending on how the plan's designed, you may very well still have coverage for services that you receive outside of the network. Again, just at a different level. And so again, if I oversimplify, we often describe Medicare supplements as peace of mind plans, and we describe Medicare Advantage plans as value plans, right? And it allows you to tailor your insurance much more closely to your actual usage. With a Medicare Advantage plan, there is essentially one health question. And in order to buy a new Medicare Advantage plan, you need to be able to say no to the question, do you have end-stage renal disease? End-stage renal disease involves kidney failure and dialysis. Most people can see this coming because most kidneys don't quit suddenly. Most kidneys deteriorate over time, and so you can see this coming. And so you can get into a type of plan that you want before the answer to that question becomes yes. In addition, many people with end-stage renal disease have successful kidney transplants, at which point the answer becomes, no, I do not have end-stage renal disease, right? And you can then again move around. Now, I've been talking about Medicare Advantage plans. Medicare supplements work differently, and this is very important, especially for those of you who are dealing with the cost plan transition. So let me talk about both groups, the people aging into Medicare for the first time and the cost plan transition. So if you're aging into Medicare, when you first go on Medicare A and B when you turn 65, or later, if you or your spouse worked later, every plan is guaranteed issue. You can buy whatever you want, they have to give it to you. That guaranteed issue period for Medicare supplements by federal law lasts 6 months. Some insurance companies, some states will extend that, typically not past a year. The longest I've ever seen is 2 years. If you do not buy a Medicare supplement within that period, the insurance company can ask you health questions. And if they do not like your answers to those health questions, they do not have to issue you a policy. And so you may not be able to buy a Med Supp in the future if you don't buy one when you first become eligible for Medicare or during a special enrollment period associated with guaranteed issue. That is what's happening for everybody else in the room. If your plan is being involuntarily terminated because the cost plans are going away, you now have guaranteed issue to buy a Med Supp from the date you got the letter announcing the termination until 63 days after termination of the policy. So basically till the end of February. And if you buy a Med Supp in that period, they can't turn you down. If you don't buy it within that period, you can only buy it later if you can get through underwriting. And so again, if you either need a Med Supp now, or you are very confident you will need, and notice I'm using the word need, not want. If you will need a Med Supp later, then you want to do it immediately. If you want to buy it, you certainly can, right? But want and need are very different and are very dependent on your budget, right? Some of you have budgets that can absorb $5,000 a year very easily. Some of your budgets are possibly a little bit tighter than that, right? And so I want to make sure that we understand that. The other thing again is, and we've got people from under 65 to, I don't know, maybe somebody's 85 in here, right? So we've got a wide range of ages, right? Many of you probably still have 5, 10, 15. Some of you may still have 20 or more years left, right? The gap in premiums over even just 10 years can easily amount to $20,000, $30,000. And so having 1 or 2 bad years at the end on an Advantage plan isn't very scary. Now, if you've only got 1 or 2 years left, that's different, right? But if you think you have a reasonably long future ahead of you, then I think it's something you need to think about very carefully because those premiums accumulate over time and you could potentially do a lot of things with that money if you're not just carrying around expensive plastic in your purse or wallet. So make sure you shop carefully. Obviously, we can help you with that. That's our whole pitch. There are business cards in all the mugs. We hope you take the mug home. That's our gift to you. Thank you for coming. There's no obligation associated with that. Take the business card home. We have offices all over the Twin Cities, including one just a couple miles from here. Yeah, it might only be 2 miles from here. Very, very close. And we've got other offices. We've got Coon Rapids. We've got Lake Elmo. We've got Eagan. We've got Bloomington. And of course, the Roseville office. So we are happy to help you with those things and sort that out. You've definitely got until December 7th. That is the end of the annual enrollment period. And you've also got that special enrollment period, which will run from December 8th through the end of February. So that there's time to do this. We've got people that can help you. We hope that you give us a call so that you can be on the most appropriate plan for both now and in the future. I do want to spend my last few minutes on this because I think it's important, and I think too many people ignore it, and it results in some pretty significant financial consequences when it is ignored. And again, for me, the big takeaway for this is not that you buy or not buy anything, but rather that you have the key conversations with your spouse or your adult children or some other caregiver so that what it is that you want to have happen is what actually happens. Okay, so this slide is about average out-of-pocket costs, and they distinguish between men and women. Women, you aren't sicker. You just live longer. That's why your number is higher than the guy's number, okay? You will also see that there is significant growth in medical spending as you age. That is the basic reality, and the big driver on the 85 plus is in fact the long-term care claims. So now we're going to start to do the budget buildup that I did much earlier. So you've got the 2018 Medicare Part B premium, the national average Medigap Plan F premium. Again, Minnesota's a little bit higher than that. The national average Part D premium, you're already at $374. If we annualize that, you're at about $4,500. If we add to that, typical, these are average numbers nationally for out-of-pocket prescription drug costs, dental costs, vision costs, and alternative care, they actually get up to over $6,000. Again, for a couple, that's $12,000. Where I live, that's a lot of money, right? And so you've got to think of where that's going to come from. What can cause those costs to accelerate as you age? Well, certainly higher insurance premiums can contribute to that. And I would want to point out something important to go back to the Medicare Advantage and supplement plans, right? Remember, Medicare supplements had a lot of guarantees. They can't change the benefits. They can't change the network. They've got to let you keep your plan if you move to another state. What can they possibly change about that plan? The premium. That's the only thing they can change. So if you all buy the plan when you're young, healthy, sprightly 65-year-olds, and 20 years later, there may be less of you, but you're older, sicker 85-year-olds, right? The premiums are going to have to go up to accommodate for that, right? And so that inflation component is real and it's serious. And there's a lot of baby boomers, and this has a good news, bad news component, right? The good news is there's a lot of people coming behind you. And so if your plan can keep a low premium and can continue to attract lots of young people, there's this wave coming in behind you. But if you live a long time, it actually starts going the other direction. And suddenly they're not bringing in nearly as many people. And so the younger you are, in my opinion, the scarier this gets. So I'm sorry for you youngins in the room here, right? Because you're just not going to have that nice trailing group that's bigger than you to help pay your bills, right? And again, that's part of what leads to, there's a totally separate conversation, right? But the financial issues that we talk about nationally when it comes to Social Security and Medicare, right? You guys were fantastic. You were working super hard. You were paying a ton of taxes. It was not a big deal paying for your parents and grandparents because there were so darn many of you doing so darn well, and there weren't that many of them. Okay, there's a lot of you who are now going to ask for benefits, and I'm not going to say you don't deserve them, right? You do. You worked hard. You paid the taxes. You did all the right things, right? But you didn't have as many kids as your parents did, darn it. And we're not doing the immigration thing anymore. We want to build big walls. So who's going to pay the taxes? Right? And I don't want that to be political. I don't want you to take it that. That's not what it's about. But if you want a lot of benefits, and you as a group, not necessarily any of you as an individual, right? But if as a country we want a lot of benefits, who's going to pay for the benefits? If we didn't have the kids to pay the taxes and we're not going to let somebody else come in to pay the taxes, who's going to pay the taxes? That's my question, right? And that's as far as I'm going to go there because I probably already overstepped my bounds, so I apologize, okay? I don't like taxes, but I mean, I do like benefits. and so I'm trying to find a balance, right? What's the appropriate balance, right? And if we keep on the trajectory we're at now, we either have to raise taxes significantly or we have to cut benefits. And I don't know anybody who likes either of those, right? I personally would just like a bigger population, right? More taxpayers. Nobody per person has to pay anymore. We just need more people paying them. So, okay, I'll stop that because that sort of stuff gets me in trouble. You can also, as you age, have changes in your health status that drive greater needs for healthcare. Some of you may be very lucky. You've only got a couple fillings in your mouth. I'll bet there's at least one person in this room with dentures. Those are more expensive than fillings. Just saying, right? Some of you may have implants. Those make dentures look cheap, okay? So that stuff changes as you age. Some of you may have these over-the-ear hearing aids. I hear they're very good. Some of you may love those very, very small inner ear sort of hearing aids, much more expensive. Just saying, stuff changes as you get older. So over a lifetime, these costs can be very large. You need to think about how you're going to pay for that, right? And long-term care isn't built into Medicare. A large percentage of people end up needing care because they have limitations with one or more areas of taking care of themselves. And the key driver is arthritis or musculoskeletal, right? You'll see at every age group, that creates more disability than anything else, right? If you can't walk, if you can't keep your balance, if you can't shower, if you can't get to and from the kitchen or the bathroom, those things drive a lot of challenges. There's certainly a lot of other things that can give you challenges, but the number one is the musculoskeletal, right? You all have friends and neighbors with canes or crutches or walkers or scooters or whatever, right? If you don't need help now, for most of you, it's just a matter of time. You'll see that some of those walking will affect almost half of you if you make it to 85. And even some of the lower things, bathing and showering, over 1 in 3 of you will have trouble with that. Nearly 1 in 3 of you will have trouble getting in and out of chairs or bed. Over nearly 25% of you will have trouble going to the bathroom. These are pretty unpleasant too, right? This is not a fun part of the conversation. So these sort of things that you may need assistance with, your children may be very good at. I'm just going to make some passing comments about elder abuse, right? Not all of your children possibly are as good as all your other children. There may be some bad apples in there, right? And while they're taking care of your grocery shopping or paying your rent payment or whatever, they may pay for something else, right? It's really important that you plan for all of this stuff while you're well and you're of sound mind and you've got people that you trust there. Because ultimately, all this stuff is going to get taken care of, but it might not last as long as you think if they spend the money on something else. Now is the time to talk about it. Have some of those tough conversations. Do yourself a favor. These are the serious ones. These are the ones that land you in skilled nursing facility care. This is a lot of what goes into that skilled nursing facility care. These are some of the costs on a per day and a per month basis for the assisted living that you can run into. I have quite a few clients now who are spending $8,000 to $9,000 a month for full-on care in a facility like that. That's $100,000 a year. I've had my record client was in a facility for 12 years with dementia before she died. It's a $1.2 million claim. If she had that kind of cash, it would have eaten it up. If she had that much insurance, it would have eaten it up. As it turns out, she had a little bit of cash and she had a little bit of insurance. And when those ran out, she went on medical assistance and she's thanking all of us for the taxes that we so graciously pay, right? But if you want to leave your money to something other than the state, right, you need to plan for this. Because the state does try to reclaim, right, those expenses, right? So when you or your spouse moves out of the house, when you finally pass, the house gets sold, the first thing that happens is the state gets repaid for the bills it paid on your behalf, right? So why plan for long-term care? I mean, there's the emotional reasons, there's the hygienic reasons, there's the financial reasons, right? But it's important for you to think about these things. 3 reminders as we wrap up before we give you a little bit of time here to ask questions. Enroll in Medicare on time. It's free to call people like me, or it should be. I don't charge anything. So there isn't, in my opinion, a lot of excuses for that. Try not to hide under a rock. If you're talking to your friend or neighbor and they don't know what's going on, have them call me, have them call somebody else, have them call the senior linkage line, right? It's not hard to get that help. We all want to provide it. Shop carefully, right? We'll talk about the cost plan transition for just a moment in a second. and then plan for higher healthcare costs in retirement. My final comments on the cost plan transition. Some of you are in either a Medicare cost plan with prescription drug coverage, or you have separate, but the separate is from the same company. Those of you are getting automatically enrolled into a new plan for next year. That plan, the insurance companies are going to tell you, has approximately the same benefits and approximately the same premiums as what you have today. That doesn't mean the network is anything like what your network is like today, right? And again, depending on what your usage is, approximately the same could be radically different, depending on your usage. So it's very important for you to look at that and compare it, right? You're probably not going to be financially ruined if you do nothing and you stay under a rock, right? Because they are giving you something that's approximately the same. But it is absolutely worth shopping that and comparing it because of the diversity of plans that are out there and the fact that since you first bought that plan, your health could have changed, your prescriptions could have changed, the doctors and the network that you're looking for could have changed, right? And so approximately the same isn't going to be right for everybody. The rest of you who are on cost plans and have separate prescription drug plans from a different insurance company or coverage from the VA, your plan is simply going to terminate. And if you do nothing, you will have nothing next year besides original Medicare and perhaps that standalone prescription drug plan. Again, there is no cost, or there should be no cost, to talk to an advisor like us. We're happy to do that for you and help you select the plan that makes the most sense. And finally, I'm going to end on the question that you asked about earlier, right? Some of these plans, if you don't buy them between now and the end of February, you may never be able to buy them again. I don't want that to sound like I'm trying to put fear into you, because you shouldn't be afraid of that. But there is a fact of the matter. If your health isn't good and you don't buy those plans now, they won't sell them to you in the future, right? And so I want you to understand that. I want to thank you all for coming out. I will stick around for questions, but we'll probably also open the doors in the back because if you're like me, you're hot, right? So thank you very much for coming out and thinking about your future healthcare.